Infective endocarditis. Definition. It is infective endocarditis. It's a microbial infection. Endocarditis. Infection of the endocardial or endothelial surface of the heart. The vegetation is a variable size amorphous mass. Vegetation is the what which can see or through the echocardiography. That is the one which is a sessile mass which develop following this microbial colonization associated with platelets, fibrin, and other inflammatory cells which attach to this endothelium. So that is the outcome of this inflammation or infection. You can see here these vegetations, like usually it is smooth, but here you can see vegetations from it's not smooth. About the epidemiology. Prior to that, we classify anyway endocarditis as acute, subacute, right-sided, left-sided, native wear, prosthetic. So once we are telling about the epidemiology, since this is the beginning stage of your clinical life, to simplify this, I would say epidemiology in broad terms. Incidence of difficult to ascertain perhaps and varies according to the location. That is other geographical factors also there. Much more common in males than in female. May occur in persons of any age and increasingly common in elderly. Mortality rate from 20 to 30%. That's the other thing. Acute one is having high mortality. What I said classification, for simplify, I will keep only acute and subacute. Later on in the discussion, we will understand further about right-sided and left-sided and native and prosthetic a bit. Acute affects normal heart valves. That's the case. Rapidly destructive. Metastatic foci is there, so it can spread. If it is in right side, it goes into lung. Try to recall the circulation. If it is in the left side, it can go anywhere in the body. Brain, kidneys, joints, leading osteomyelitis, renal abscess, brain, cerebral abscess likewise. Common organism is Staphylococcus aureus. If not treated, usually fatal within 6 weeks, even more early. About subacute, you can see often affects damaged heart valve. Subacute case is it's a long or prolonged clinical histories there, time to time on and off fever. In acute case, maybe 2 or 3 days associated with fever, loss of appetite, that's constitutional symptoms with maybe on and off chest pain, maybe. And unexplained, no focus of infection is there. Subacute also same, it can be commonly present at pyrexia of unknown origin. So indolent nature, if not treated, usually fatal by 1 year. It's slow, it goes slowly. Let's move to pathophysiology. So as I said earlier, it's in a normal valve, it's smooth. Other thing is normal blood flow is perhaps smooth, but once turbulent blood flow develop, that leads to traumatization of the endothelium. You can imagine, I think it's a turbulent blood flow in any blood flow, any fluid flow, which can destruct these barriers. So initially it develops non-bacterial thrombotic endocarditis. That is, no bacteria is there. Due to this turbulent blood flow, it leads to traumatization of the endothelium. So it's kind of trauma, like what has happened to skin. Similar thing has happened in here. So platelet will aggregate and other inflammatory cells and other chemical compounds will accumulate and leads to thrombosis or thrombotic formation. That's the thrombotic endocarditis. That is, inflammation is there, thrombus is there, but it's non-bacterial because there is no infection. And time to time, we'll further discuss. Anyway, transient bacteremia can happen. Often even when we brush our tooth or maybe having some eating something, oral flora, or maybe there are micro damages, and because oral flora is rich in bacteria, they can ooze into our enter in our blood cell or circulation. But it's transient. But once there are some destructive nature is there, or non-bacterial thrombotic endocarditis or kind of things are there, this bacteria, transient bacteria, can go and lodge in these thrombus, and that's how it happens. So now it can be there, and slowly they can grow depending on the type of organism. That also matters for development of subacute to acute. If it is a highly virulent pathogen like Staph aureus there, it causes acute. If it is coagulase negative one, so even virulent uh, streptococcus, less virulent, viridans streptococcus, because it's rich in our oral flora, which develops subacute form. So anyway, these are in the they are within this uh, thrombus. Meanwhile, once microorganisms there, later on it can be reached covered with these fibrin and platelets. So at the same time, now it's a rich media for their growth, and it happens slowly depending on their virulence. At the same time, imagine here blood is there, blood flow. Now it's like abscess, like even fibrin formation, and it's confined. So imagine when we are going to treat, we are in a grave or great difficulty because antibiotics should penetrate this. Otherwise, how the antibiotic can kill these microorganisms? Imagine. Okay, right. Pathogens is what I said. Simplified, altered wall surface, deposition of platelet and fibrin, bacteremia. What is happening? So hemodynamic factors for turbulence flow. Then bacterial colonization more like to occur around lesions with high degree of turbulence, such as small ventricular septal defects, valvular stenosis. So large surfaces are low flow and low turbulence are less likely to cause infective endocarditis. If that is large VSD, if it is smaller, turbulence is high. So you can see again same thing. Okay, endothelial cells here initially, but now it is bacterial, which because rich in bacteria. Then non-activated platelets, everything activated platelet, subendothelial matrix. Likewise, even they reach in activated endothelial cells. How it goes? Bacteremia, what I said, transient bacteremia. I think in bloodstream infection we have discussed several type of bacteremia. Transient and persistent, like persistent low and high, and intermittent bacteremia. Here, transient bacteremia when heavily colonized mucous surface is traumatized, dental extraction, even with the brushing, periodontal surgery, tooth brushing, tonsillectomy. Likewise, biliary tract surgeries, they are rich in enterococcus. So, site of infection, aortic valve more common than mitral. Aortic vegetation usually in ventricle aspects, and all three cups usually affected. Perforation or dysfunction of valve, root abscess there. Root abscess is one of a complication of these vegetations. So then we have to go with valve resection and go with the artificial valve. Prosthetic valve we have to implant once it's done. Otherwise, patient will die because it can dislodge this aortic valve completely, lead to complete heart failure. Mitral dysfunction by rupture of chorda tendon. You have to know what is chorda tendon. That's the reinforcement of or helping material to cups to move up and down or open and closer. So once this dysfunction of mitral valve happens, one this chordae tendon is infected and they can rupture, chordae rupture. So clinical manifestation, fever, most common symptom, anorexia, weight loss, malaise, night sweats, heart murmur, maybe newly diagnosed heart murmur, you can see. Petechiae on the skin, conjunctiva, and oral mucosa. Splenomegaly. Right-sided endocarditis is not associated with peripheral emboli, what I said, because it goes to the lung phenomena, but pulmonary findings are predominant like pneumonia, multiple lung abscess, micro abscesses likewise we can see. So you can see about the symptoms and signs for how it present. Common one is the fever. So about petechiae, it's a non-specific presentation, but there are splint hemorrhages as well. It's a splint hemorrhages observed when you are looking clinical examination. It's very much to see. When you are suspecting infective endocarditis, always have to try to elicit these signs. Non-specific, but ocular nodes and Janeway lesions are specific. It's happened often in left-sided endocarditis. And more specific, painful and erythematous nodules. You can see painful erythematous nodules. While Janeway lesions are non-painful, more specific, you can see Janeway lesions. Splinter hemorrhages, fatigue. Diagnosis. Mind you, we need two criteria. This was developed by Dukes and it termed as Duke criteria. It includes predisposing factors, blood cultures, that's the main one, and echocardiographic finding. I think you can see it's a major criteria and minor, but major microbiological, that is typical microorganisms isolated from two separate blood cultures, such as Viridum Streptococcus bovis, Hasek group, Haemophilus agrictobacter, Cardiobacter, Eikenella, and Kingnella, Staphylococcus aureus, or commonly acquired enterococcal bacterium without a primary focus. So what you have to know is microbiological. You don't want recall of if you like. It doesn't matter. We are not asking what is you have to do. You don't want to recall what is the criteria. But if you know major criteria, one is microbiological, other one is about this echocardiography. Those two they are definitely, that is no harm. Two major criteria. It's definite. Infective endocarditis. Likewise, it's there. Minor criteria is there. Predisposition to infective endocarditis that includes certain cardiac condition and injection drug use. So it's in our country nowadays, they are no, we can't say no, and certain cardiac conditions, high risk conditions. Then fever, vascular phenomena, like what I said, then immunological phenomena, having rheumatoid factor, glomerulonephritis, and ocular nodes, and microbiological other minor findings and markers of inflammation, those will matters. So two major, just get idea. They are a definitive, possible, and rejected. That is, we exclude the infective. There is no infective endocarditis. Echocardiograph bit. We do transthoracic, okay, or transesophageal, going via the esophagus. It's an invasive test. Just get the idea. That will be enough. So you can see a vegetation. So valve, and there is attachment. This is vegetation. Perhaps microbiology is very important since virulence of the infective organism is a significant factor in determining the success rate of both medical and surgical treatment. So microbiology, what I said, this is native valve with this prosthetic valve in early. Streptococcus are the commoner. Then Staphylococcus are there in the prosthetic. Endocoagulase positive as well as coagulase negative, CONS. And gram-negative aerobic bacilli are also there. Usually Pseudomonas coliforms, those are usually, they don't cause infective endocarditis. Chlamydia rickettsial are there. We can't grow them, so we have to appreciate with the what it's in the Duke's criteria about the antibody and IgG levels. Blood culture, that is the essential. What is important is minimum of 3 blood cultures. Usually if you are suspecting acute bacterial endocarditis, we have to take 3 blood cultures in 3 separate 20 fungocytes, obtain 10 to 20 milliliter in adults and 0.5 to 5 ml in children within 1 hour. You take 2 in same time and take another one in 1 hour and start antibiotic as soon as possible. But if you are suspecting subacute bacterial endocarditis, you don't want to rush. You can get two blood cultures same time, and third one in 6 hours, so even 12 hours. Because now patient is somewhat stable, but having some pathology, so we can wait. Then we can start empiric antibiotic. But in acute case, mind you, it's an emergency. You have to do as soon as possible once you are suspecting, and give antibiotic as soon as possible once blood culture is obtained. Otherwise, blood culture yield or culture ability or getting the positivity will be less. Typical organism present in at least 2 separate samples. That's one criteria. So about the complications, we will deal with the treatment, but about the complications as well. So this, I think you can imagine this. So it's there. So it's in the floating in the blood. So it can be a embolism. Embolism. It can develop embolism. So meanwhile, you try to classify this as systemic and local complications. So systemic complication. Again, systemic complication, metastatic spread of infection. Meanwhile, it can lead to systemic formation of immune complexes like glomerulonephritis and arthritis also. Same time, they can give osteomyelitis, what I said in left side, right side can give pneumonia. Local spread of the infection, it can go to annular ring abscess, that is around these valves, and rupture of the valves, coda rupture, and even not cardiac failure and death, complication, death. So local spread can go. Acute staph aureus infective endocarditis, perforation of aortic valve and aortic valve vegetations. Abscess extending to myocardium. You can see, okay, how it goes. Management. Our main target is sterilization of vegetation with antibiotics, prolonged high dose and bacteria. So we have to give prolonged. So not as usual pneumonia or even bloodstream infection, we have to give minimum 28 to 42 days, 4 to 6 weeks. It depends on the etiology. At the same time, we have to go high dose, slowly metabolize in bacteria because, as I said, and due to high density is there.